So without further ado, I'm going to invite Ruth Larch to take the podium, the Clinical Director of Waikato DHB. It says here on the piece of paper, so I hope that's right, because I just know you as Ruth, you know.
Thanks, Laura. Yeah, Ruth works well for me. Thank you very much. I mean, I've had the misfortune of actually missing most of the conference, which is bitterly disappointing for me. Unfortunately, I've had an unwell colleague, so I've had to fill in, and I'm going to do a little bit of a fly in and fly out, so to speak. I'm a rural hospitalist, I'm an emergency physician, and I'm the chair of the New Zealand Telehealth Forum. I live and I work and I play in a rural area, and my passion really is access to healthcare, particularly for our rural patients and consumers. So I am interested in how many of you live in a rural area. Do we have any fellow rural folk at all? Woohoo! Yay! Oh, a little smattering, yay. Oh, a little whole table over there. Awesome. And how many of you work in a rural hospital? I'm looking back over there again and back over here again. Awesome, excellent. Thank you very much for all the work you do, by the way. So 1.5 million patients, or no, I shouldn't say that, 1.5 million people live an hour or more away from a tertiary hospital. Those aren't the people I'm going to talk necessarily about today. I'm going to more focus on that percentage of our population, which is 10%, who find themselves in a rural hospital, because we're talking about deteriorating patients, detecting deterioration in the hospital setting. So I come from the Waikato, and I work in the Waikato District Health Board. We've got 4 rural hospitals where I work. Thames Hospital, which is the main hospital that I work at. It's actually a 52-bed hospital, so it's the biggest rural hospital in the country. With 52 beds, we have surgeons and physicians. We have 3 other rural hospitals, as you can see there, Tokoroa, Te Kuiri and Taumarunui, all with a varying number of beds. And this brings up a really important question, which is actually, what is a rural hospital? Oh, my slide lost the hospital. That's entirely fitting, isn't it? Typical, see, there's a first inequity there, right there. And, you know, an awful lot of what we talk about when we define rural hospitals is really doctor-centric, which I find really interesting. You know, if you look for a definition of rural hospital, it's all about, well, you know, the doctor's a generalist, you know. In the old days before rural hospital training, which isn't that long ago, we talked about a facility where acutely ill patients are admitted and cared for solely by generalised doctors. Often these were GPs with a special interest, and there still are many GPs with a special interest in rural hospital medicine. We do now have a division of rural hospital medicine which delivers vocationally trained rural hospitalists like myself, and we don't, to the best of my knowledge, do that for our nursing colleagues, and I have to say that we've got an enormous number of nursing staff who work in rural communities, nurse practitioners and clinical nurse specialists, and this is a real workforce issue supporting those people also. So we don't have a very good definition, that's the first start. You can see here that one definition is also a hospital in a rural setting, at least 30 minutes from a secondary or tertiary level based hospital, where acutely ill patients are usually admitted and cared for by, again, the generalist doctor, and who may as a consequence be required to practice in a variety of different vocational domains at any one time. Now this is important too, because we don't have intensivists, we don't often have anaesthetists. 1 minute you can be repairing a tendon, the next minute you can be called to the ward and you've got somebody who's crashing and you need to intubate them. So it's a huge variety of practice, and it can be pretty scary. So here's the little clip from the Division of Rural Hospital Medicine, which sits under the New Zealand College of General Practice. And you'll note there that you can be a Swiss Army knife of medicine, which is kind of cool. I'd say that there's certainly maybe, you know, the corkscrew part and the knife part. I'm not sure about all the other bits, but it just gives you an idea of that sort of generalist that's required. This is the Rural Health Roadmap, and I'm sorry you can't read that, but for those of you who are unfamiliar, we've actually got an advocacy body, which is the Rural Health Alliance Aotearoa New Zealand, and that's a group of advocacy bodies, including Dairy Women New Zealand, a number of district health boards, all of which are saying we need to do more for mental health in New Zealand, we need to, rural New Zealand, we need to be more mindful of what's going on out there. And they point out that 10% of our GDP is produced by our primary industry. Now, amongst all this, we also need to be really mindful that if you're Māori and living in a rural area, your outcome is significantly worse than if you're white and living in a rural area. So just because you're rural doesn't necessarily mean that everybody's outcome is going to be different. Māori do significantly worse in rural environments than Pākehā, so just be mindful of that. So like I say, approximately 10% of New Zealanders live within the catchment area of a rural hospital. And over 40% of admissions to those hospitals are patients who can be cared for within those hospitals. So the other proportion will move out. If you've fractured your hip, you're not going to be able to stay in your rural hospital unless you're planning on dying there. In a 2011 survey of rural hospitals, these doctors really described a sense of isolation. Again, we don't have this sort of information. There's not a lot of studies done in rural hospitals. That's changing in the last few years, but I didn't come across anything which described our nursing staff, but I bet you bottom dollar that they feel it even more acutely. We talk a lot about air transfers. There's been a lot of emphasis, I know, this year, given the air ambulance review. We've talked a lot about how important air transfers are, but I would say that air transfers are not always preferable in an emergency. We need to be mindful that there's more than just our air ambulance whizzing around, that our volunteer firefighters, our volunteer ambulance staff are a really important part of our rural communities. And they'll often come in when we've got a in-hospital emergency too. And of course, inter-hospital transfer by air is the single most expensive non-therapeutic intervention that's available to a hospital clinician. And at the moment, that resource is immobilised. It's often immobilised too, but it's unmonitored. And that's important to notice also, because a lot of our patients who deteriorate in hospital, when you actually make that decision in a rural hospital, where are they going to go to? You don't have an intensivist. Sometimes it's just one doctor, sometimes it's not a doctor. Sometimes it's your nursing team who helps those people. Communication with a base hospital is often considered difficult. So for those of you who are working in a base hospital here, I beg you, please be nice to your rural colleagues. Next time you drive through a rural town, look at the hospital, think about what they're dealing with, and just say, yes, certainly, let me help you. Now, one of the other really interesting things statistically is that patients who are admitted initially to some peripheral hospitals will have fewer interventions and they'll have a poorer outcome than patients admitted with exactly the same condition to a larger tertiary hospital. And that's a reflection on either skill set, resource. Not every hospital in New Zealand has a BiPAP machine, for example, or an Airvo for babies. So there's a really big resource issue. And there's often an increased complexity with managing patients in a small community. You may know intimate details about whoever's come in to see you and with their whānau, and that can, making decisions with those family members, particularly around death, how are things going to go if you do deteriorate, can be really difficult when those are with friends. Now, this is a really important point as well. Clinical outcomes of critically ill patients transferred to tertiary ICUs in New Zealand have a different case mix, have a higher severity of illness, mortality and length of stay, and associated costs in the non-transported patients. So what that's saying to me is at the moment we probably, we talk about this door to deteriorating patient to door time, sorry. So our deteriorating patient to door time to an intensive care unit is really huge, and the patient who deteriorates in a ward is going to do a lot better than a patient who deteriorates in a rural hospital setting, because you're not necessarily going to be able to mobilise the same resource. Rural hospitals are staffed differently and they've got different training needs, and the Health and Disability Commission has recognised that smaller hospitals require a system of support and backup where potentially unstable patients can be easily transferred to the larger centre. And I think that's really important for everybody who's working in those base hospitals to think about, how are you supporting your tertiary hospitals? Your rural hospitals. Are they receiving the same level of care? If they deteriorate out there, what are you going to do for those patients? Because they're our patients too. So what does this all mean? Well, Deterioration pathways may need to be altered for the local environment. You may only have 2 responders to a patient who deteriorates. There may be other things that you need to think about, other people who need to be in that skill mix. How do you make a call once you've actually detected that somebody is, their use score is worsening, getting higher? Who's going to be the next body? How do you make that call to the tertiary centre? I don't have all of these answers. We're working on these at the Waikato at the moment. And I'll show you a little bit of that next. But, nursing staff may need a variety of avenues to seek help for their patients with worsening use scores. In many of these hospitals, they can be on their own overnight. And it can be really difficult for a nurse at night to wake somebody up. And one of the things that we've talked a lot about in Thames Hospital is, well, how about if you've got a patient who's deteriorating in the ward, how about you have access to a senior nurse at Waikato Hospital, rather than feeling that, you have to talk to, wake a sleepy doctor up. And I think that behoves all of us to have a think about how we assist our colleagues in those centres. And I think every tertiary and secondary receiving hospital should have a pathway to aid and receive the deteriorating patient in the rural setting, just as they would in the ward. In terms of the future, so I'll show you this. So that's a funny little clip really, but that's one of our infectious disease consultants who's going off on a ward round in Thames Hospital. And we've got a couple of different ways that we can have ward rounds in our place now, which are all delivered by telehealth. And of course, I'm incredibly biased, being the chair of the New Zealand Telehealth Forum. But one of the things that really drives my desire to see more telehealth out there is the fact that you can have somebody present at the bedside, maybe not physically, but pretty close to, may not be a physical set of hands, but you'll get another brain and you'll get some more support, and the patients can feel a lot more supported also in that setting. And another really good example of that is in stroke. If your patient's having a stroke on the ward, we now have a facility to be able to have a stroke physician talk that patient through what the alternatives for treatment are. And I think that's really important. There's no, just because you live in a rural area, just because you live in a rural hospital should not therefore mean that you do not have access to subspecialty care. And that's me.